Good morning. These are my disclosures. First of all, I'd like to thank the HRS for creating this online forum for us to present our data. And now, on behalf of the Praetorian investigators, I'd like to present the investigator-initiated Praetorian trial with the title A Prospective Randomized Comparison of Subcutaneous and Transvenous ICD Therapy. The background of this study is that transvenous ICDs are effective but come with major limitations, especially that in 10 to 20% of the patients there's a lead failure after 6 years of follow-up. For that reason, subcutaneous ICDs were developed to overcome these lead-related complications. Currently, we only have registry data on these SICDs, and these studies were mostly done in young patients with relative preserved ejection fractions. They've shown a high shock efficacy, they've shown less ICD-related complications, but they've also shown more inappropriate shocks. Currently, no randomized controlled trials are available that compare these two therapies. So therefore, we designed the Praetorian trial with the main hypothesis that in a typical ICD population, the SICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events, being inappropriate shocks, ICD-related complications that require intervention with a special focus on lead-related complications. If we then look at the methods of our trial, you can see our inclusion criteria: patients over the age of 18 with a class 1 or 2A indication for ICD therapy for primary or secondary prevention according to current guidelines. Major exclusion criteria were indication for pacing therapy, being Brady, CRT, and ATP. Another major exclusion criteria was failed SICD vector screening. When you then look at the figure, you can see the flow chart of this trial, and you can see that between 2011 and 2017, 849 patients were one-to-one randomized, where 426 patients ended up in the SICD arm, and 423 patients ended up in the transvenous ICD arm. This was performed in 39 centers in the EU and the US, and we then followed our patients for a median follow-up of 48 months, for the primary endpoint being complications and inappropriate shocks. And since inappropriate shocks are part of the primary endpoint of this study, we mandated standardized ICD programming with major components of that being delayed therapy and high rate cutoff. If you then look at the baseline characteristics of our study, you can see that we achieved our goal of investigating how the SICD operates in a traditional ICD population. Our median age in our population was 63. More than 90% of patients had an ischemic or a non-ischemic cardiomyopathy. About 20% of patients had a secondary prevention indication, and the median ejection fraction was 30%. And now for the main results of our study. At 4 years, you can see that the primary composite endpoint of inappropriate shocks and complications occurred in the transvenous ICD arm in 15.7% of the patients. And I think that the big news of this study is that in the SICD arm, there was no difference with, at 4 years, the occurrence of the primary endpoint of 15.1% in the SICD. And this means that the SICD is non-inferior to the transvenous ICD with regard to this primary endpoint with a p-value of 0.01. And if we then look at the individual components of the primary endpoint, we do see a difference, and especially a difference in trend. When we look at the inappropriate shock rate, you can see that in the SICD this was 9.7% and 7.3% in the transvenous ICD arm. There's a trend towards a difference, but this was not significant with a p-value of 0.14. If we then look at the device-related complications, we also see a trend, but then the other way around. So there are less SICD-related complications, 5.9% versus 9.8%. This difference was also not significant. When we then look at the numbers associated with these figures, you can see that the primary composite endpoint occurred in 68 patients in both arms. and that when we look at the individual component of inappropriate shock, that occurred at 41 versus 29 in both of the arms. I think it's important to mention that the main driver for inappropriate shocks in the transvenous ICD arm was AFib and SVT, and the main driver for inappropriate shocks in the SICD arm was cardiac oversensing. When we then look at the device-related complications, we also see a difference, 31 versus 44 in the transvenous ICD arm. There were more infections in the transvenous ICD arm, but this was counterbalanced by more bleedings in the SICD arm. The major difference in numbers between the complications was caused by lead-related complications, as you can see over here. And you can see that even better when we portray that in a figure. As you can see over here, 1.4% lead-related complications for the SICD versus 6.6% in the transvenous ICD. And this was highly significant. Obviously, it's important in any ICD trial for efficacy and safety to look at mortality. And you can see that there was no significant difference in mortality in the trial, with a special focus I want to make that the sudden cardiac death rate in both arms was exactly the same, 18 versus 18. The only difference in numbers between mortality were mostly driven by non-cardiovascular death, 31 versus 22. Therefore, I'd like to conclude that in a conventional primary and secondary prevention ICD population, SICD is non-inferior to the transvenous ICD with respect to major ICD-related adverse events. There's no difference in ICD complication rates, although there was a trend towards more shock in the SICD arm. There was no difference in inappropriate shock rate, although there was a trend towards more shocks in the SICD arm. And I need to mention that the ICD complication trend was in favor of the SICD. Especially less lead-related complications with the SICD, 1.4 versus 6.6%. Therefore, we conclude that the SICD should be considered in all patients in need of an ICD without a pacing indication. Thank you, and I especially want to thank all the persons that were involved in this trial in all the Praetorian sites, but also the trial office. I'd like to mention that the data will soon be published in one of the major scientific journals, and I also would like to mention that we extended the follow-up of the Praetorian trial with another 4 years. Thank you very much. With regards to the publication I just mentioned, I'm happy to be able to share with you that the full dataset of the Praetorian trial is in press at the New England Journal of Medicine. Unfortunately, due to the corona pandemic, the publication date is still unclear.
Thank you for the opportunity to comment on the Praetorian trial. I'd like to start by congratulating the investigators on the completion of this important trial. It is indeed great to finally have a randomized clinical trial comparing the SICD with the transvenous ICD. As you heard from Dr. Knox, the SICD was found to be non-inferior to the transvenous ICD in its effect on the primary endpoint of inappropriate ICD shocks and complications. Numerically, there were fewer complications with the SICD, but these were counterbalanced by a higher number of inappropriate shocks in the SICD arm. However, it is important to keep in mind that the trial was not powered to look at these two endpoints separately. I was curious to see the numbers related to non-cardiovascular death, which appeared to be higher in the SICD arm. It's possible that this may be due to a higher rate of comorbidity in the SICD arm, as we were not able to see those data. But based on the baseline characteristics that the authors shared with us, it appears that the randomization worked in that trial. So I doubt that the comorbidities were not evenly distributed between the two arms. And I would love to hear from the investigators their thoughts about this finding. As we all know, the SICD has evolved, and with this evolution, the newer devices are better able to discriminate VT from other potential causes of shocks. I doubt that the investigators have adequate numbers, but if they do, it would be great to examine the rate of inappropriate shocks by device model. So what are the clinical implications of the Praetorian trial in the majority of patients with ICD indications who don't need to pace and who pass the screening test? The option of an SICD versus a transvenous ICD should be presented to the patient. However, I personally would not extrapolate the results of the Praetorian trial to every patient we see in clinical practice. And I'm really intrigued by the role of the SICD in patients with HCM who are known to be at a higher risk of inappropriate shocks. It would also be really great to see if these results can be replicated by other groups. We know of at least one other randomized clinical trial comparing these two types of ICDs. And I'm really excited to hear that the investigators have extended follow-up in this trial by 4 years. Again, congratulations to the team.
This is Eric Prostowski, and I'm speaking as the hawk, the bird of prey, on this study by Dr. Knopson and Associates, the Praetorian study, which basically looks at a comparison of subcutaneous ICD with a transvenous ICD. And the study was well designed, and they did meet their goal, which was non-inferiority. So you have to look at more detail and say, what does this all mean, and what do I do with these data? So there were too few people, in my opinion, in secondary prevention group for me to make any comment at all. I think there were only 19% of the total study population. So I do not think these data apply there. And I also am concerned about there are too few hypertrophic myopathy patients, and they can be a problem with sensing with a subcutaneous device. So I'd be a little careful looking there. There was an equal number of lead problems or basically complications. So the two were comparable. They had different, as we all know from previous studies, they have a little different mix there. The thing I was a little disturbed by was there was a 6% of inappropriate shocks in the transvenous lead group. And there are lots of ways to avoid inappropriate shocks. And I think 6% is way too high in the modern era. So I was a little disturbed to see that and not quite sure why that happened. So in the end, what do these data mean? Let's say they're equal as far as problems are concerned. Then you have to decide which patient will you select. So, okay, I think that's fair for primary prevention, but there are two other things you must consider. First of all, you should definitely consider the cost. Now, maybe it's different in Europe, but in the United States, the subcutaneous ICD is significantly more expensive. Second of all is the battery life. We really don't know the comparison there, but in some of the transvenous ICDs, now the battery life is quite long and certainly is going to outlast the subcutaneous ICD. So what is my conclusion? I think the study result was sort of anticipated in my opinion. I wasn't surprised by it. They have different complications, but they sort of come out in the wash. I think it boils down to a primary prevention patient who doesn't need pacing, who you don't think is going to need CRT, and who you feel that maybe it's okay to go ahead and use it, and you're not worried about the money or the longevity. I'd say take your pick.